Just a minute, please.
Hello.
Yeah. Could you able to hear now?
Good morning.
Yes.
Good morning.
Good morning.
Good morning.
Now, everybody is could able to hear me now?
Yes.
Fine.
Yes.
Now it is good.
We'll be starting the program now today. Sorry for the inconvenience. We had some technical problem in recording. I put it on the YouTube for recording, which I could not do it. Now, today's guest is Dr. Saibal Moitra. He'll be speaking about the Allergy March. You see, the Allergy March is commonly seen in the atopic family, and it is not well understood by most of the specialities, and it has to be communicated to the most of the specialities. The reason behind is the management, especially in emergencies as well as in the long-term management. And doctors of different specialities like ENT, dermatology, pulmonology, and GI tract disorders specialist could not able to understand what is allergy march is. And the understanding by allergy march, I think the management becomes very easy, and the long-term management becomes very comfortable, and we can deliver a quality of life to these allergy atopic people. With all this understanding, we know that the airborne sensitivity in the beginning, slowly it becomes into the respiratory allergy. And now the second wave of this food allergy is coming into the picture. And we have to make to understand this food allergy do have any role becoming a respiratory allergy in the later days to come. I think Dr. Saibal Moitra will be giving you more explanation on these factors. And also we have certain questions to be raised, whether this atopic march is only restricted to the IgE sensitivity or even into the non-IgE sensitivity also. And also in the population with attention deficient, that is hyperreactive people population, do have any role as in the allergy march. And also atopic children delivering through the cesarean section also prone for allergy disorders. So these are the factors which we have to see. And also a food allergy is precedes allergy airway disease. So various questions are arising, and this is a good beginning with allergy march, and we should be responsible in giving a understanding to most of the people who are dealing allergy disorders in allergy march. I invite today as a chairman, Dr. P.C. Katuria, to occupy the chairman post and conduct the meetings and introduce our chief guest. And I invite Dr. Saibal Moitra also to the meeting. Dr. P.C. Katuria, please.
Okay, thank you. Am I audible?
Yeah. Dr. P.C. Katuria is a leading senior physician, chest physician at Delhi, and he has got more of academic interest, and especially focused more on the molecular biology, and he's very fascinating with biologicals in the management of allergy disorders. I call Dr. Katuria to go ahead with the meeting.
Okay, thank you, Dr. Nagendra. My due regards to my seniors, Dr. M.K. Agarwal, Dr. A.B. Singh, Dr. S.N. Gore, Dr. Deshpande, and the most senior-most faculty member, Dr. Gautam Bhagat. My greetings and congratulations to all. We got gold medal yesterday by Neeraj Chopra, and today our focus is on also the great day, the great speaker, Dr. Saibal Moitra. Before I request Dr. Saibal Moitra to present, I take the opportunity to have some words on atopic march. The nature has given us a very wonderful, excellent, beautiful, perfect immune system. During pregnancy, the fetus acts as a foreign body to the mother. But the mother cannot reject the fetus because of her biological needs. She has to accept it, but at the cost of her immunological system. Her immune system during fetal environment is a predominantly prototypic Th2 cytokine, IL-4, IL-5, IL-13, allergic, Ig mediated in nature. Does it mean that all the baby at birth will be allergic? No. Again, the nature has given at the time of the birth of the baby, there is a sudden immune deviation from Th2 to Th1 to balance our immune system, and the baby at birth is normal. But in contrast, if mother is allergic, mother is atopic, mother eats the allergenic foods, then the epitopes of the allergenic molecules passes to the placenta. Ig antibodies does not pass through the placenta. It is the epitope which passes and can sensitize the baby, and so the Ig synthesis starts in utero. Who knows whether the baby will become atopic, progressive, or regressive? Depends on the various factors. My teaching says, if we look at all the RCT clinical trials done on this, why this baby is becoming progressive and why the other baby is not progressive depends on the 5D. Number D is a dry skin. Means if there is a mutation in the surface epithelial protein, that is the flagrin, most of these children, they have got a dry skin and most of them, they become progressive. Second D is a diet. You see, mother milk is the best milk. But if the mother milk does not contain the HMO, human milk oligosaccharides, because it is the oligosaccharides which maintain our immune balance. But in some atopic mother, the recent trial is there that mother of a allergic mother milk of the allergic is containing the less HMO rather than the healthy mother. So some of the children, even if they drink mother milk, they can become progressive. Third one is a vitamin D deficiency. Now, if you look at the GINA guidelines, now there is a one full 2 lines are there that in mother during pregnancy, vitamin D deficiency should be monitored, or if mother plan to become pregnant, vitamin D deficiency has come a big parameter. Number 4 is a less exposure to the dirt, because dirt contains the live bacteria which synthesize the polysaccharides, and these saccharides also activate or maintain our microbiodata. And the 5th one, which is less exposure to the denders, because these denders, whether it is a cat and a dog, have got 2 sides of the coin. One side of the coin that you are getting exposed to the microbiota of these denders, and the another side is allergen. Now there is a cut-off time has been mentioned in the literature that it is less than 1 year, it is a good microbiodata. After 1 year, it may become nuisance to the child. So 5D are prone to develop the progressive atopic march. So with these few words, I request our guest speaker, Dr. Saibal Mohatra. Dr. Mohatra, as you know, is a well-known pulmonologist in Glen Eagle Apollo Hospitals, has a vast experience of more than 25 years. After doing post-graduations, he took interest in allergic disease. He is a man of many talents, teaching skills, as well as the academic skills, as well as the performing the many conferences. 2 of his conferences I attended, one drug allergy and one was on, I remember, genomics. That was very well acknowledged, most of us. He is the man who has done research on T lymphocytes in bronchial asthma. His work has been well acknowledged, published more than 30 national and international papers, has written many articles in the books. He's a very charming, personality, very compassionate personality in totality. With these words, I request Dr. Maitra to kindly present his presentation. Over to Dr. Maitra.
Thank you, Dr. Katuria, for all these words. First of all, I would like to thank the Allergy Chat Forum for allowing me to present my today's talk. And I pay my respect to all my senior colleagues and also my teachers. And I pay my respect to Dr. Nagendra, Dr. Agarwal, Dr. Bhagat, Dr. Singh, Dr. Gaur, and obviously my humble respect to Dr. Katuria and Dr. Singh. My talk has been made much easier by Dr. Katuria because he has just set the ball rolling by just bringing into forth some very salient features and salient points, and which actually is needed to be understood while we are seeing an allergy patient. More so, the initial questions which has been raised by Dr. Nagendra is very much pertinent. And he has just in a way summed up the entire thing that allergy is a multidisciplinary science, and which actually takes into account not only the clinical sciences, including the pediatrics, the dermatology, the pulmonology, the ENT, the gastroenterology, but also the basic sciences, namely the immunology. Okay. So with this, let us start a talk on the allergic march, because this allergic march actually it highlights that when we are seeing an allergy patient, maybe as an ENT surgeon, we are seeing allergy patient as allergic rhinitis. We treat the allergic rhinitis, maybe the patient becomes asymptomatic, and we say that we have done the job and we have treated the patient well. Then what happens is that maybe again the patient comes up with some skin conditions, goes to a dermatologist, the dermatologist sees the patient, cures the thing, and the patient becomes fine. Dermatology feels that he or she has done his or her job. Similarly, then the patient lands up having an asthma. So then the pulmonologist comes into the picture. He or she treats the asthma, controls it, and feels that, okay, we have done our job. It is similar to like that old story which we all read about that 7, 8 blind men who are actually just touching an big elephant, and so they are describing the elephant in the way the part they are touching. One who is touching the trunk, he is saying that the elephant is how it is. One is touching the tail, one is touching the legs. But what happens is that since they are blind and they are only touching a particular aspect, they are not seeing the entire elephant. So that is it. We all need to open our eyes when we're actually dealing with an allergic patient. So then only we'll get the whole story or the whole picture of what is it, and which will enable us to treat the patient in a much better way, so that the patient can be given a better quality of life and we can prevent the further complications occurring in that same patient. And that is how we go about in actually approaching an allergic patient, treating an allergic patient. And that is how this specialty is different from any other specialties, as which where we just see the patient at one time and treat the patient. Okay. So with this short introduction, let us go into the topic. Is my screen visible?
Yeah, it is visible.
Continue.
Okay. Thank you. Okay, so today's talk is basically on the allergic march, which we also call an atopic march. So let us start with this case. A 6-month-old boy with a history of moderate atopic dermatitis was referred because of concern of food allergy. The child was exclusively breastfed until 6 months of age, when he developed acute hives, vomiting, and respiratory distress after his first consumption of cow's milk. In the medical history, his medical history was otherwise notable for infantile onset atopic dermatitis that was poorly controlled with intermittent topical corticosteroid use. And there is a family history of allergic diseases also, like his father had atopic dermatitis and asthma, mother had atopic dermatitis, and his older sister had food allergy, atopic dermatitis, and asthma. As we all know, allergy runs in the families. So this is an allergic family, and this child was first seen in by us with a history of the moderate atopic dermatitis. The immunocap was done to see the specific IgE, which confirmed the diagnosis of food allergy to milk. There was specific IgE to the food allergy to the cow milk was quite high, and the child was instructed to avoid this food. An alternative atopic dermatitis therapeutic regimen was initiated, which included more frequent and higher dose of corticosteroid use, and his skin improved during the following weeks, along with the adequate use of the emollients. The child was followed in my clinic, and his atopic dermatitis significantly improved by the age of 2 years. And the family was happy. We were happy also, and because the child became well. But what happened that winter, he was admitted to the hospital for respiratory distress, which we were not aware of, because then the parents thought that he got some infection. They took him to a pediatric emergency, and he was having respiratory distress, and they were setting the setting of a viral upper respiratory tract infection, saying he had to be admitted. Well, so, and then he became well, and he was discharged from the hospital. The following year, what happened is that he developed an allergic rhinitis, and then he was again and brought to our center, to our department, and at that time his skin test results was positive to trees, grasses, and house dust mite. That means he showed sensitization to the tree pollens, the grass pollen, and the house dust mite, both Dermatophagoides sphaerini and Dermatophagoides sterolicinus. So we saw that how this child progressed from initially having an atopic dermatitis to some respiratory issues and then allergic rhinitis, and his sensation pattern also. Initially he had IG, specific IG to the cow milk, but later on he developed more sensitizations, that is to pollens and the house dust mite. So what we see, this is called atopic march. This atopic march actually refers to the natural history of allergic diseases as they develop during infancy and childhood into adulthood. It was introduced by the American allergists, this term, Coca and Cook in 1923. The term atopy became closely associated with the IgE molecule and its identification as the carrier of hypersensitivity. So this term became very closely associated with the IgE molecule. But I would again say that what Dr. Katuria has said, because now we have, apart from the IgE mediated pathways, we have non-IgE mediated pathways also, as we know now. However, in the context of the atopic march, it is very important to understand that IgE is only a single pathophysiologic mediator of some, but not all the atopic diseases. So that is, we always have to keep in our mind, because what happens is that we give too much emphasis or too much focus on the IgE. In that way, what happens is that we try to forget about the non-IgE mediated mechanisms and the pathways, which may be important in a particular patient. I'm not talking about that this will be important in all, but maybe in a subset of patients that may be important. And if we don't keep that in mind while we're evaluating the patient, we might fail to give a proper diagnosis to that patient. So the problem is, once a child has commenced on the atopic march, it is difficult to halt the progression. Now the question is, when and where does this atopic march starts? Does it start after the birth, before the birth, or during the birth? As you'll understand that Dr. Katuria was saying that a fetus is basically, they are Th2 primed. Okay? But after the birth, usually what happens in the most of the individuals, they shift from the Th2 to a Th1 type of response, the T helper response. But in some individuals, because of various reasons, which includes the genetic factors, which includes the factor relating to the childbirth, whether the child was born by cesarean section or the vaginal delivery, factors, other environmental factors, which could be the child rearing practices, the food habits, the environment. So there may be many multifactorial things which actually can lead to the continuation of the Th2 response in that particular child. And now we are trying to understand, rather we are understanding now more and more that what are the factors which is there which causes the enhancement of the Th2 response and its continuation, and what can be done in a way so that we reduce the Th2 response, and maybe we actually help to control the asthma, the allergic diseases in a very early stage. So this I won't call a primordial prevention. No, it's not, because since it's genetically linked, but this can be more called a primary prevention. That is, the preventing the diseases is to come into fore when actually we have this opportunity to control it. Well, this is a developing, evolving science, and we are actually progressing in that front. So, classically, the atopic march begins with atopic dermatitis and progresses to marked IgE-mediated food allergy, asthma, and allergic rhinitis. Why I'm stressing on this IgE? Because so far, my presentation, the data which I have, is all based on the IgE-mediated diseases. Okay, so means the march that we'll see over here is classically the IgE-mediated march. In the non-IgE-mediated diseases, we have something else that is more of a complex picture, and I thought that I won't bring it into this because that might need a separate lecture. So today, mainly, I'll be stressing on the IgE-mediated atopic march, which we see the most common in our day-to-day practice. So if we see here, that is in the early stage, it is the atopic dermatitis. Then comes the wave of this food allergy. Then later on comes the asthma, and still later the allergic rhinitis. But it does not mean that in every patient, it will be the same temporal relationship. It might go from back and forth. It might just shuffle from the back and forth, and maybe all the diseases might occur at the same time in a particular individual. Then some might progress, some may not. All these permutations and combinations can occur in each and every patient. So the atopic march, usually to be put into a very simplified form, it starts with an atopic dermatitis, goes into an allergic rhinitis and asthma, and there can be an intervening food allergy. Or the food allergy may start early with atopic dermatitis, then progressing on to an airway allergy. So this atopic dermatitis march actually describes the progression of atopic disorders from eczema in young infants to allergic rhinitis and asthma in the older children. This was the definition which was given by Curd and Hartert in 2009 or by Donald in 2011. So why it happened? What are the similarities between all these conditions that one is actually following the other or maybe occurring at the same time, though they're involving the different organ systems? Number one, they share the common genetic and the environmental predisposing factors. The predisposing factors, as Dr. Kathuria and Dr. Nagendra was talking about, that is, which includes the genetic propensity and along with that, the environmental factors. The environmental factors includes both the environment in which the child is growing and also the factors related to the childbirth and the food habits of the mothers and all. These are all important. They share the immunologic feature of one or more allergen-specific Th2 responses. This is very important to understand because all these diseases, when we talk about, they are actually Th2 diseases. So it could be an allergic rhinitis, it could be an allergic asthma, it could be a food allergy, or it could be an atopic dermatitis. We are basically the Th2 diseases. Now we are actually expanding the term and we call it more as a T2 disease than a Th2 disease. But why? What is the difference between a T2 and a Th2 disease? The only difference is that in the when we talk about the Th2, we put more emphasis, or actually we tend to highlight more the activity of the T helper type 2 cells. We know this T helper type 2 cells, basically they are the type of the T helper cells which actually releases a certain area of the cytokines, namely interleukin 4, 5 and interleukin 13, which actually mediates this specific type of the inflammatory response in a particular organ. Now, why we have just shifted, or rather shifting to the T2 response? Because now we understand that how the T cell behaves, that whether the T cell will behave as a Th2 or a Th1 or a Th17 or a Th3 or whatever it is actually modulated by the environment in which that the T cell is developing, or when the signals that the T naive cell, the T naive cell means it has not differentiated into a particular Th a subtype. When we call it a T naive cell, it's in the environment in which it is getting the signals from the various antigen presenting cells or the allergen presenting cells, and moreover the signals which is coming from the cells which belong to the innate arm of the immune system. What are these cells? Namely the epithelial cells, the macrophages, as the natural killer cells. These cells are basically the innate, belong to the innate arm of the immune system. In them, we know that there is a particular cell belonging to the innate arm of the immune system, which we call the innate lymphoid cell type, innate lymphoid cells, so the ILC cells. Now, these ILC cells are also various types. There could be ILC1, ILC2, ILC3, and ILC4. So maybe because of some chemicals which is released by the epithelial cells, some signals which can involve many other cytokines or interleukins like the thymic stromal lymphopoietin, interleukin 33, 25, and whatnot. It actually causes the development of a specific type of the innate lymphoid cell, which we call it ILC2. Interestingly, this ILC2 also releases the same set of the cytokines which the Th2 cells release, that is the interleukin 4, 5, 13, and it produces it in much higher amount. So if a T naive cell gets a signal from the antigen presenting cell in an environment where there is an increased amount of this Th2 cytokine, it differentiates into a Th2 type of cells, and then it carries as the race forward. So that's why we are shifting more towards upstream to understand that what is actually happening and why this cell is becoming a Th2, or maybe who was Th2, it is not changing into the Th1 after childbirth. So third thing is that they're characterized by a type 2 effector phase. This we all call a type 2 effector phase that include generational specific IgE by the mast cells, by the plasma cells, the activation of the mast cells, and the other innate features such as the mucus production in the airways, the edema, or maybe the inflammation in the skin. Okay. So we have namely 4 sets of disease. One is the atopic dermatitis and the IgE-mediated food allergy, which we call an early members of the atopic march, or we have this asthma and the allergic rhinitis, which we call the late members of the atopic march, because they usually come somewhat later than the other 2 diseases. So let us try to understand that what are these diseases and how are they linked. So atopic dermatitis, we know it's a very common pediatric condition. It is mostly diagnosed in the first 6 months of life before the development of the food allergy, allergic rhinitis, and asthma. And we have specific guidelines, we have the tools by which we can diagnose the atopic dermatitis. It's more of a clinical diagnosis. So it results from the disruption of the skin barrier because of some intrinsic defects of the epithelial cells, as Dr. Katuria was saying, because of the filaggrin gene deficiency, mutation in the filaggrin gene, which can cause the deficiency of the filaggrin protein, which acts as a cementing material between the 2 epithelial cells. And there are other genes also which are involved. Now we have an array of genes which is involved, which causes the barrier dysfunction in the skin, and which will lead to a genetic and environmental predisposition to type 2 inflammation. So as is one of them is the filaggrin gene. So, but we need to understand that is loss of function mutations. Now we know many things. We know this. What is a mutation? What is a loss of function mutation? What is a gain of function mutations? And now we talk about this loss of function mutation and gain of function mutation during the viral replication also. Because you must have heard that while we talk about this is the COVID, that is SARS-CoV-2. We have seen that when there are some viral studies going on in a specific lab, so gain of mutation function or the gain of function in the gain of function mutations is actually are quite dangerous. But here it's something opposite. There is the loss of function mutations in the filaggrin gene. It do not increase the risk of the food or allergen sensitivity independently of the atopic dermatitis status. That means there are other factors also which are needed to actually cause this atopic dermatitis. Other factors means which are the factor that we all were talking about so long. So therefore, although intrinsic epithelial barrier dysfunction is central to the pathophysiologic makeup of atopic dermatitis, there are other important genetic and or environmental modifiers that are required for the development of the allergic skin inflammation and the progression of the atopic march. Of this, one of the most important environmental modifier which is coming in, which we're trying to understand more, is the microbiota or the microbiome status of the skin. Is very important. The microbiome status of the vaginal tract of the mother, microbiota of the GI tract, microbiota of the respiratory tract, which actually it modulates and it leads on to certain important changes as in the various organs and causing, which can actually give us some protection against some allergic diseases. So then we come to the food allergy. It is more proximally situated in the atopic march. Proximally means the early members of the atopic march. And the presence and severity of atopic dermatitis is positively correlated with the risk of developing the food allergy. So means more severe the atopic dermatitis, more chances of developing a food allergy. So this is just an analogy. Here you can see that an infant placed on the front to sleep is up to 6 times more risk of having a certain infant death syndrome than one placed on the back. Similarly, a recent review estimated that children with atopic dermatitis are as much as 6 times more likely to develop food allergy compared with the healthy peers. So that means that the more bad skin we have, the more chances that the child will develop one or the other food allergy sooner or later. And the food-specific IgE responses can be detected in the first months of life, and they peak at approximately 10% prevalence at 1 year of age. Why? Because where does the child get exposed to that food? Now we know it's not by eating or drinking, one gets exposed. It is the transcutaneous migration of the allergens which causes the sensitization in that particular child. So more bad or worse is the skin, more extensive is the atopic dermatitis. Increased allergens is entering into the system through your that is the loose epithelial barriers, and there's more chances of developing a food allergy later on. That is, a transcutaneous sensitization is now known to be one of the major factors leading to the sensitization of to the various food allergens. Okay. So the fact that sensitization occurs before food ingestion most cases suggests that it is through this inflamed skin as opposed to the GI tract. In addition, there has been positive correlations have been found the use of wheat or peanut containing food skin products, because which are mostly used in the Western countries. Here we don't. And the development of wheat or peanut allergy respectively. And exposure to peanut dust in child's home positively correlates with the likelihood of developing the peanut allergy. Here we see another kind of allergy, that is the sesame, allergy to sesame, because sesame or the till, because you have seen this practice maybe in very rural areas to apply in this till oil on the baby's skin, and that's why this sensitization to the sesame is increasingly high. It's increasing. So these all the sensations is occurring to the skin. So together, these findings support the theory that there is transcutaneous sensitization of food allergens in susceptible individuals. We all have to keep in mind, whenever we talk about the allergy, we think that why it started, when it started, how it started. So it's a continuum of the processes. So the atopic dermatitis or the food allergy is also very much highly linked to asthma and allergic rhinitis. We know that the association between atopic dermatitis and respiratory allergy is influenced by the atopic dermatitis severity. Around 20% of children with mild atopic dermatitis develops asthma, as stated by a study, but more than 60% with severe atopic dermatitis will develop asthma in the study. So the presence of atopic dermatitis is also associated with increased asthma severity and greater asthma persistence into adulthood. So if a pediatrician or a pulmonologist is seeing a child with the asthma and he or she doesn't take the history of an atopic dermatitis, which might have been there before, and how it was and how severe it was, how long it was treated, then one fails to understand, because if the child had a history of severe atopic dermatitis or maybe having an atopic dermatitis, then one can think that it will be difficult to control all the asthma in this child, and this child will persist the asthma and can go on to the development and other fixed airway diseases maybe later into the adulthood. So the presence of food allergy is also an independent risk factor for the development of allergic rhinitis and asthma. We know this unified airway disease concept has come up. So the food allergy was suitable development of asthma. The odds was 2.16, means more than 1. And rhinitis 2.72. The odds of developing the asthma in those who had atopic dermatitis is higher than who did not have atopic dermatitis. Also, the food allergy to peanut, milk, and egg, they were significantly associated with subsequent development of the asthma, which we found is the highest in case of the peanut, and also in rhinitis also highest the odds was with that of the peanut. So the food allergy predisposed patients to allergic rhinitis and asthma independently of the atopic dermatitis status. Whether the patient had atopic dermatitis or not, this food allergy also increased the risk of the asthma allergic rhinitis, suggesting an additive risk of developing new allergic conditions as one progresses on the atopic march. So maybe if one did not have atopic dermatitis but had a peanut allergy, we should always keep in mind that this child might develop an asthma or a rhinitis later on. So all these are the important risk factors in the development and the progression of the allergic airway diseases, namely allergic asthma and allergic rhinitis. So this is a unified airway disease concept. It is a clinical association between allergic rhinitis and asthma is well established. I don't need to reiterate it again. You all know it. And very well, you have been seeing the patients and who come up with both the conditions and mostly with up to 3/4 of individuals with asthma reporting the rhinitis symptoms. And observations indicate that the upper and lower airway behave as a physiologic and a pathophysiologic unit. It is a single physiologic and a single pathophysiologic unit, because what happens in the upper airways, it gets transmitted to the lower airways. What happens in the lower airways gets transmitted to upper airways. There is always a continuous crosstalk between the upper and the lower airways, both in the cellular level, in the cytokine level, and also in the epithelial level. So this has to be kept in mind while we're dealing with these diseases. So the study has demonstrated that all children with moderate to severe persistent allergic rhinitis develop asthma. I don't know where these things have come into the slide. Well, I'm sorry about it. Anyway, so means it says in the we can have the intermittent, mild persistent, and the moderate persistent, and the number of patients with the allergic rhinitis, it is quite high in this the intermittent and group. Now this is quite interesting. The number of patients with asthma at 5 years of age and follow-up, we see that the moderate to severe patients, they usually have most a high amount of this is patients, they have this asthma. This is the group. So that means it is interesting to note that both allergic rhinitis and the asthma, the allergic asthma, they are linked. And when the disease severity is less, as means in one part, it might be quite higher in the other part, because maybe of the translocation of the various inflammatory cells and the mediators into the lower airways. So what is the immunologic mechanisms underlying the atopic march? So what are they? So the immunologic mechanisms underlying the atopic march, this I have tried to simplify it as much as possible. So this is usually the classical pathway which we talk about. This is the external environment, all the allergens are in the external environment. Now this is the epithelial barrier, which is somewhat defective. Now these allergens, they come inside, they are taken up by the antigen presenting cells, as mainly the Langerhans cells or the dendritic cells. And after taking the antigen presenting cells from there, they migrate to the local lymph nodes, because mainly the antigen presentation occurs at the local lymph nodes. And there, the antigen presenting cells, they present it to the T naive cells, and along with that, they give the signals along with the MHC class 2 proteins. And these signals, actually, they causes the activation of the T helper cells and their differentiation in the Th type 2 cells. And this Th type 2 cells then starts releasing multiple cytokines, namely interleukin 4, 5, 13, and also releases as many chemokines also. And these chemokines and the cytokines, these all actually then leads to the actually for the accumulation of the other cells which belong to important cause of the inflammation of the type 2 type, namely the eosinophils, and which come into the picture. And then apart from that, it causes the B cells to change into the plasma cells, and these plasma cells then, and there we know there's a class switching occurs in the plasma cells, and so from the IgG they start producing more of the IgE, and this IgE then goes increase its number, it goes and sits it's on the mast cells, and this IgE bound mast cells, when they get exposed again to the allergens, there's a cross-linking of the IgE which is there on the mast cells, which leads on to the downstream signaling pathways, namely including the STATA6, and causing the release of the granules, which is there in the muscle, which causes lots of chemicals are released into the vicinity of the muscles. Out of them, one of the important mediators is the histamine. Apart from that, there are hundreds of other mediators which is released, which then brings about the specific inflammatory response in that particular organ. So this is important to understand. This last, that is the presence of a Th2 response to one allergen could potentiate the development of the additional Th2 responses. This is what is we call it Th2 mediated amplification of the responses. So if someone has a Th2 has developed, which is actually towards a specific epitope, okay, maybe of some say peanut or maybe some pollens. Okay, so then when it has developed, and in that milieu where there is more of the IL-4, 5, 13 as produced by the Th2 cells or maybe by the innate lymphoid cell type 2, so they actually then recruits or amplifies the allergic responses, so that there starts the development of the clone of the Th2 cells of the against the epitopes of other allergens also. It's a very unique feature of the Th2. Why? Because it is called a Th2 amplification. You know how this Th2 amplification is occurring. Basically, this amplification process is a defensive process. What happens is, say a bacteria which has entered into the system and it has been engulfed by a particular antigen presenting cells, and that usually what happens is that this antigen presenting cells won't present the entire the bacteria to the T cells. It will break down the entire thing and present only a particular part of the antigen to the T cells. That part of the antigen which is recognized by the T cell or the antibodies, we know it is called epitope. But what happens is that when a particular epitope has been presented, the T cell clones develops into a clone of cells against that particular epitope. But the bacteria has other antigens also. So what happens is that this development, well, in case of bacteria, it's a Th1 response, but same thing happens over here in Th2 also. So what happens is that the clone of cells, which has developed again a specific epitope, it causes us the increased chances of recognizing the other epitopes and developing the clone of cells to the other epitopes, so that the body can harbor a much strong defense and much stronger army, rather say army of cells, as again that particular microorganism. And so what happens is that so the body fights back fiercely and it controls the infection. Same thing happens in case of the allergic reactions, but here, unfortunately, more fierce reactions, it leads on to more trouble. And the child or the patient and develops allergenicities to multiple other allergens, which makes the problem more difficult to handle. But that is how it goes. That is how the immune system works. It tries to protect us from the foreign thing, but unfortunately, this foreign an antigen or the protein is harmless, that the defense system is not able to understand. So we call it a dysregulated immune system. So allergy is actually a dysregulated immune response. Now, what are the clinical strategies which are there aimed at prevention and intervention on the atopic march? General strategies is that as the epidemic increases in prevalence and severity of allergic conditions observed in recent decades, they're generally thought to have occurred too quickly to be attributed to the genetic drift alone. Genetic drift is the slow changes in the genetic composition which occurs over a decade, and which leads to a increased causation or decrease of a particular disease. But the other factor is a genetic shift, where there's a rapid change is occurring, or maybe some environmental factors which is causing some rapid change, or some mutations in the genetic makeup which causing an increased prevalence or incidence of a particular disease in a community. So as a result, a considerable effort has been devoted to understanding the role of diet. As Dr. Katuri was talking about the 5Ds, I was listening, and really means that is, he has summed up the solution for all. The role of diet, the hygiene, the infections, the allergens, the air pollution. We know the pollutants now playing such a big role in actually orchestrating these responses in our body, and other environmental factors in susceptibility to allergic diseases. Particular attention has been given to the influence of the pathologic or commensal microbial stimuli. That is, now we know, that is the microbiome of the entire system of the entire human being is important, and this microbiota in the GI tract, the skin, the respiratory tract, it shapes our immune system and directs its activity. Then the antibiotic exposure markedly restructures the intestinal microbiome and skews the immune system towards the type 2 inflammation. Why? Because this intestinal microbiome is important in maintaining a balance between the Th2 and Th1. So what happens is that when these intestinal microbes are destroyed by antibiotic, it skews it towards a Th2 response. And associations have also been made with childhood exposure to household pets, livestock, unpasteurized milk, endotoxins. So the early exposure to pets before 1 year of age may be beneficial, but late exposure may be harmful, as in the dog allergens. In one study in Finland and Russia, a significant dose-dependent reduction in the risk of atopy was associated with microbial exposure and the prevalence of the enteroviruses. We all know about the hygiene hypothesis. So this is the endotoxin in level exposure in the environment or in our homes. It actually decides it's that how our immune system will function. Higher endotoxin level exposure is known to be associated with a better Th1 response and a lesser Th2 response. So this is a RCT which was done with a peanut consumption in infants at risk of peanut allergy, which showed that to prevent food allergy, they emphasized visited oral peanut exposure. Why? Because the dose is much more higher, and this high dose of an allergen at times it has been shown to actually dampen the immune response or maybe shifting of the immune response to the Th1 type. This is the published. Now we have this probiotics. Since the microbiota is gaining importance, so this probiotics is gaining importance, and we see in the market is filled with a plethora of the probiotics. But as of now, the probiotics has not been shown to have an important effect in modulating in the microbiome structure, though theoretically it is. So the probiotic type and the nature, which is shaped by our mother nature, is actually it is more important. So by the best we know that the best milk consumption, so the type of the oligosaccharides which is going into the through the breast milk into the child, it actually shapes the intestinal microbial structures. So however the data to mixed and some positive studies, so means, and though the studies are ongoing and more data will come and accumulate, but what should be the probiotic composition, and that should be given to have an unified response in each and every child, it's still we haven't achieved that. Right. So according to the WHO guidelines, and the currently available evidence does not indicate that probiotic supplementation reduces the risk of developing the allergy in children. And why? Because maybe we have not achieved that particular combination of the probiotics, which is going to bring this change. Optimal atopic dermatitis therapy. Recently, a double-blind study examined the benefits of the pimecrolimus as therapy in 3 to 18 months old patients and in atopic dermatitis, but no significant differences was found. Another small trials upon routine use emollients reduces the incidence of atopic dermatitis, though it's a common practice in our culture. So it is good. Actually, it reduces the allergic sensitization in that particular child. Antihistamines, there is no significant difference between treatment with high dose and placebo with regard to development of the asthma. So these are the drugs which are important in controlling the symptoms, but they have no effect in stopping or halting the atopic march. So the influence of anti-allergic drugs, so there is not much evidence. But important thing, another tool that we have is the allergen immunotherapy. The evidence suggests that allergen immunotherapy may prevent the progression to asthma in high-risk atopic patients if their treatment is started early during the course of the disease. So the allergen exposure going to effector cells allergic responses to mediators allergic responses, then to allergic symptoms. So these are all the areas where this thing acts. So these symptom options only provide symptomatic treatments. We can see the anti-IgE, the mast cell stabilizers, steroids, antihistamines, lipotriceptor antagonists, beta-2 agonists, decongestive. All these are able to control the symptoms of that particular disease at that particular point of time of the allergic march well, but they do not prevent the progression of the allergic march. But it is the immunotherapy, which is, so the allergen avoidance and immunotherapy are the only treatments that modify the course of an allergic disease either by preventing the development of the new sensitivities or by altering the natural history of disease or the disease progression. So we have multiple evidences in it, though the evidence for preventive immunotherapy is low, but for the other immunotherapy, diabetes and asthma is quite high. Yes. So now, yes, so this is all the immunotherapy. So now the key message is the atopic march begins with atopic dermatitis, progresses to Ig-mediated food allergy, asthma, rhinitis. And once individual has commenced on an atopic march, it is difficult to halt the progression. And atopic dermatitis is allergy immunotherapy is the only disease-modifying therapy for the treatment of the allergy diseases. Thank you very much for the patient hearing. I'll be happy to answer some.
Thank you, Dr. Maitra, for enlightening on the various aspects. Rightly, you said that it is the through the skin which activate the Th2 cytokine rather through the mucosa. Very good points you raised. Now, how the atopic march progresses because of the certain predominant factors which you mentioned, and also there are certain slips between the cup and lip. Many questions are there. So in view of that, I just go through the chat box. One question is there, and no question is there. So ask to any questions regarding the atopic march, we'll be happy to answer. Any of the panelists, comments?
Dr. Sharma.
Welcome, Dr. Sharma.
Yes.
Very critical appraisal of our.
Yeah. Anyway, first of all, my sincere good morning to all seniors and eminent pulmonologists, allergologists of India. A beautiful deliberation, outstanding deliberation, and really I appreciate a lot. There are certain factors, and my query is, what could be the factor which influences the allergy mass, number one? Because allergy is not just an allergy disease. It is a combination of environment, epigenetics, food, and the environment which is intrauterine, time of the delivery, and the food is available. Smoking has a very strong reasons which influences allergy march to a great extent. And what you address, the Th2 amplification, making the clothes, definitely a very new concept, which I also understand. One of my submission is, with the changing in the environment developments, endocrine disruptor chemicals have come up in a very big way. Like we have a packaging foods, beautiful packages which carries high amount of phthalates, which again results in different kinds of allergies. Bisphenol A, which we have in plastic bottles, which gives you high incidence of bronchial asthma, which this